Introduction of ICD-10-CM. Hello, thanks for joining me today. Today we're going to review over the introduction of ICD-10-CM. I suggest that if you have an ICD-10-CM book, that you grab it. You may pause this presentation at any time by clicking on the pause button located under the presentation lecture. Today's objectives are: we're going to discuss the structure of the ICD-10-CM book. We're going to speak about the conventions. We're going to discuss how to locate your codes. And we're going to talk about important guidelines found within your ICD-10-CM.
There are two main sections within the ICD-10-CM layout. You have your alphabetic index or index to diseases. This is where you're going to find diagnostic terms listed in alphabetical order. This is where your coding begins, okay? Then you're going to verify these codes in your tabular list, which is found towards the back of your book. So your coding starts with the alphabetic index or the index to disease is the same thing. And where you verify your codes is your tabular list. So it starts there and then you go to your tabular list to verify your code.
Medical necessity. The diagnosis code ICD-10-CM needs to justify the procedure code, which is CPT codes when you're coding for physician. If you're coding for inpatient, it will be PCS codes, okay? But for the sake of it, we're going to speak of physician only because this particular class is going to focus in on the physician coding. So, the diagnostic code, which is your ICD-10-CM code, needs to justify your procedure code, which is your CPT code. And what this means is if a patient is diagnosed with having a fracture of the leg, okay, that will be your ICD-10-CM code, and the fracture is being repaired, that's your CPT code. That's the procedure being done. So the fracture being repaired needs to be related to that fracture of the leg. So it needs to be a repair of leg fracture with a diagnosis fracture of the leg. Okay, so now let's talk about the sections that you're going to find in your ICD-10-CM book. You're going to find one of the largest sections in this book, which is your index to diseases. That's going to be your first section. Then after that is your neoplasm table. Following your neoplasm table is your table of drugs and chemicals. And lastly, you're going to find your index to external causes of injuries. Now, these are the sections that you're going to find before you get to your tabular list, okay? Okay, when looking up codes, you will need to make sure you're looking up codes according to the main term. What is defined as the main term? The main term is the condition, the disease, the disorder, the complication that the patient is presenting with. So if a patient comes in and they're diagnosed as having an infection, okay, just say the patient has a urinary tract infection. The problem with the urinary tract is that it's infected. So you will look up infection. That would be your main term, okay? Like this example that's on the screen. The complication is the fact that this patient has a mass in the abdomen, okay? The location is the abdominal area. So the main term would be mass, and the subterm would be abdominal, okay? Now this particular code further specifies the specific location within the abdomen where the mass is found. So you will look up mass, abdominal, and then if you have more specific information, you will code it to whether it's diagnosed as being located in the upper gastric area, whether it's generalized, whether it's in the left lower quadrant, or if it's in the periumbilical area. Of course, that will be based upon the documentation. So the physician diagnosed the patient as having an abdominal mass in the upper gastric area, you would code it as R19.00. If it's diagnosed as being in the periumbilical area, it would be R19.05. Okay? The tabular list. The tabular list is found behind your external causes index, okay? The tableau list contains 21 chapters back here. There are categories and subcategories. The codes are between 3 to 7 characters, which includes letters and numbers. There are 7 character extensions back here. Now, when you're looking at these codes, you're going to see symbols next to these codes letting you know how many characters are required for this to be a complete code. So if you see a check 4, that means there are 4 characters required for the code to be complete. If you see a check 5, this alerts the coder that there's 5 characters needed for this code to be complete. If you see check 6, that means there are 6 characters required for this code to be complete. If you see check 7, that means there's 7 characters required for this code to be complete. Now, if you see check X7, that means there are placeholders required and 7 digits in total to make this code complete. Okay? Conventions. NEC stands for Not Elsewhere Classified. And these type of codes are found in your book. And they are actually, if you're using the ICD-10 CM book that is an AMA book, your NEC codes are actually highlighted in gray. Okay? These codes are specific as the ICD-10 CM book allows, which means the physician documentation is specific, but if you look in the book, there's not a specific code for it within the ICD-10 CM book. Then you have the NOS code, which is not otherwise specified. Okay? And what that means is the physician wasn't specific with the diagnosis code, but the ICD-10 CM provides a specific code for that particular condition. Sometimes physicians aren't specific just because they don't document information because of bad documentation. Or it could be that the physician is working up a definitive diagnosis but does not have one available yet because maybe the patient is new, a new patient, and the physician's trying to find out what's going on with the patient. Like for instance, the patient comes in and the patient has a tumor in the breast. The physician may not know whether it's cancerous or not. So you may have an unspecified code for that specific location of a breast mass, okay? But then when the physicians get a definitive diagnosis and say it's breast cancer, you have a definitive diagnosis that is specific, okay? So the NOS codes, again, are used where there's no specific diagnosis documented by the physician, but there's a specific diagnosis available in the ICD-10 CM book. Then you have brackets. In the tabular list, they're used to enclose synonyms, alternate wording, or explanatory phrases. But if you see these brackets within the actual index to diseases, what it means is that 2 codes are required. So you'll have HIV, for example, a patient has HIV with encephalitis, and say the encephalitis is due to the HIV. You will look the code up, you will see that it's B20, and then you will see in brackets that you also have G05.3. The way that would be coded is you would need to code the B20 first, because it's listed first, and then that code in brackets will be coded second, which is G05.3. You need not to draw brackets around the second diagnosis code. Those brackets are just there to let you know that there are 2 codes required to effectively describe this diagnosis. Parentheses are used to enclose supplementary words, okay, and these supplementary words are also known as non-essential modifiers, which means if this information is documented within the record, the further specified diagnosis is not going to change the code. So if a physician documents the patient has acute rickets, the code is going to be E55.0. If the patient is documented as just having rickets with no specific information, the code is going to be E55.0. So as you can see, even though the diagnosis was more specific in the documentation, it didn't affect the code. So it's considered, the information within the parentheses is considered to be non-essential modifiers. Other specified codes. These codes are also known as your NEC codes that we spoke about a little earlier. These codes end with the number 8 or 9 as the last character. Again, these codes are used when the physician is specific with the diagnosis code, but the ICD-10-CM book does not have a specific code for that diagnosis. And these codes are highlighted in gray in your tabular list. Okay? Unspecified codes, by the way, are highlighted in yellow in your tabular list. Okay? And these codes end with 9 or 0. And these codes are used when the documentation is not available because the physician wasn't specific with his documentation. These codes are also referred to as NOS. And we talked about that a little earlier. Okay? Not otherwise specified. Okay, so now let's talk about includes and excludes. Includes means that if you see a diagnosis with an includes under it, what that means is that the diagnosis listed with the includes will also fall within this category or subcategory. If you look at F18, inhalant-related disorders, it says that it includes the volatile solvents. So the patient has volatile solvents, it's included under this category. Okay? So you would code from F18 category. If you look at excludes 1, when you're looking for an example, you can go to F17. F17, nicotine dependence, has an excludes 1. History of tobacco dependence, Z87.891, and tobacco use, NOS, Z72.0. And what that means is that if a patient comes in and they have a history of tobacco dependence, you will need to go to the Z87.891 code instead of looking at the category F17 codes. Okay? Because this is not where you belong. If you look at F17, and you'll see there's also an excludes 2 note, which states tobacco use, smoking during pregnancy, childbirth, and the puerperium is coded Q99.33. Toxic effect of nicotine is coded T65.2. And what excludes 2 means is that the patient can have a nicotine dependence, which is the category F17, and they can also have one of these diagnoses as well. So these 2 diagnoses can be coded together if both of the diagnoses are documented within the documentation. When coding in your tabular list, there are notes back there, of course, that we've discussed. You're going to use an additional code when you're directed to do so. If you look at code R65.20 in your tabular list, you will see that you're told to use an additional code to code for specific acute organ dysfunction. And there's a list of some of the examples of what the organ dysfunction may be. And what that means is that the R65.20 will be coded. Then you will need to code a second code after that code because it tells you to use an additional code. So you're adding that code. So you would code whatever that additional code may be. So for example, the patient was diagnosed with severe sepsis and the patient had acute kidney failure. You will code R65.20 and acute kidney failure will go second, which would be N17 point, whatever the additional character will be based on documentation. Then you will code also a code first with this code. So you have the R65.20, you need to code an additional code, and you need to code a code first because it's telling you code first underlying infections such as, and it gives you a listing of what those infections may be. An example is sepsis NOS.
which means the patient's been diagnosed with severe sepsis, but a specific type of sepsis was not listed. Like, it's not specific, as if, the patient could have had E. coli sepsis due to E. coli, but in this case, we're saying it's NOS because the documentation did not specify that the severe sepsis was due to E. coli. So you would use the NOS code, which is the unspecified sepsis. So we're going to pretend that the patient was diagnosed with severe sepsis. Along with that, the patient had acute renal failure. So you need to code a code first, which a code before the R65.20 is required. And in this case, we're going to have the sepsis NOS, which is the A41.9. Then you will code the R65.20. And then the additional code would be the N17 point, whatever that last character would be based on documentation. So in order to code severe sepsis, there will be 3 codes required. Okay, you need to code a code first, then you would code the severe sepsis, and then you would need to code an additional code, okay, to represent the organ dysfunction or failure. You also have the option to code an additional code if applicable. And what that means is if the documentation is available for you to code an additional code, you would code that additional code. An example would be if a patient was obese and the documentation actually gave you the patient's body mass index. You would code the obesity code along with the body mass index. But if the body mass index information was not available, you would not have to code the body mass index separately. You'd be okay with just coding the obesity by itself. An eponym is a disease or syndrome named after a person. Okay. Modifiers, which we talked about a little bit. We talked about the non-essential ones, which are the non-essential modifiers. If the documentation is available and you're coding from that documentation, even though the documentation is there and the code is specific, the code does not change. For example, when we talked about rickets, if the patients know that they have active rickets, the code will stay the same. If the patient is documented as having rickets, it's going to be the same as if the patient was documented as having active rickets. The code will not change. Then you have essential modifiers, which are also known as subterms. When you look at your code book, your main term, and then like 2 spaces over, that's where you'll see your subterm. These are considered to be essential modifiers because in most cases, they do affect the. When looking in your book, sometimes you will notice that you will see the word "and" within the description of the diagnosis code. "And" can mean "or," okay? An example would be a patient that is diagnosed with having an injury of the shoulder and the upper arm. It can mean the shoulder or the upper arm. "With" can mean due to. A patient may be diagnosed as having liver disease due to chronic alcoholism. Okay. It can mean same as with alcoholism. So it can be documented either way. Okay. The documentation can say liver disease with alcoholism, chronic alcoholism, or it can say due to alcoholism. So if you see it documented as with, it can also mean due to. C will direct you to a more specific term. So if you're told to see, you need to see. Okay, you need to go to that specific term if they're telling you to go see something. Okay. Well, C also means that there may be additional information available for you to choose the correct code. So you will need to see that diagnosis as well. The point dash just indicates that this code is not complete. Additional characters will be needed to complete this code. Section 1 of the guidelines contains structure, conventions, and general guidelines. Section 2 and 3 is inpatient principal diagnosis and additional diagnosis guidelines. Section 4 is for outpatient guidelines. Outpatient is also referenced in sections 1, 2, and 3 as well. Let's discuss the steps that you guys will need to take to identify or to find your ICD-10-CM code. You will need to find the main term first. So you will look at the diagnosis and determine what the main term is. A lot of times when looking at your main term, the main term, if the word in or the diagnosis ends with the word infection, like urinary tract infection is going to be your main term. If the diagnosis ends with syndrome is going to be your main term. If your diagnosis ends with the term disorder, like bipolar disorder will be your main term. The same goes for disease, like chronic obstructive pulmonary disease. Your main term is going to be disease. So a lot of the terms main terms are easy to figure out if the main term is disease, syndrome, disorder, or infection. Okay, and a lot of times when you're looking up codes that ends, or diagnosis that ends with that particular term, one of those terms, you will look these diagnoses up from right to left. Okay? For instance, COPD, you will look up disease, pulmonary, chronic obstructive. Okay? For urinary tract infection, you will look up infection, urinary tract. Okay? And that's basically how you will look these words up, or these diagnoses up. You're going to also need to make sure you refer to any cross-reference notes under the main term. You're going to make sure you read all the information that's within those parentheses. You're going to refer to any modifiers, which are non-essential or essential modifiers. You're not going to skip the subterms. You're going to look at every single subterm that's listed under the main term. If you're told to see also, see also. If you're told to see, you need to make sure you see. Make sure you use your cross-reference instructions. If you do not find your main term within your book, or you don't understand what the main term means, you can always use Google, or you may use a medical dictionary. Okay. After you have found your code in your alphabetic index disease, you have to verify your code in the tabular list. Okay, so you will go to your tabular list in the back of your book. You're going to find the code that you found in your index to diseases, or your alphabetic index in your tabular list. You're going to review all the notes that are there. You're going to make sure all the characters are there. You're going to make sure you pay attention to the includes, excludes, 1 and 2, and any additional notes that are found within the tabular list, because your tabular list is going to have to help you code correctly. Conditions that are an integral part of a disease process, you do not code separately, which means if a patient comes in and the patient has symptoms, and those symptoms are associated with the definitive diagnosis, you're going to code for the definitive diagnosis only. So if a patient's diagnosed with gastritis, that's a definitive diagnosis. But the reason they came in was because the patient was diagnosed with abdominal pain. The abdominal pain is associated with the gastritis, so you're going to code the gastritis only. Conditions that are not an integral part of the disease process, you will code separately. So if a patient came in and had abdominal pain, along with that they had earache. The definitive diagnosis in this case was the gastritis, but by the way, this patient had an earache, because the earache will be coded separate because it's not associated with the gastritis. Okay, so when you have symptoms or complications that's not associated with the definitive diagnosis of why the patient came in, you can code them in addition to that diagnosis. Signs and symptoms. In the outpatient setting, you will not be able to code for probable, suspected, questionable, rule out, differential, or working diagnosis. Your diagnosis has to be specific when coding for the outpatient physician, or just the outpatient side of coding. You have to make sure the diagnosis is specific, definitive. So if the patient came in, the physician said this patient probably had something, you cannot code the probably. You would have to code the symptoms that the patient came in with. Whereas if you're coding for inpatient, you can code for probable, suspected, questionable, rule out, differential, and working diagnosis, as long as it's being worked out. But for outpatient, you cannot. The only diagnosis you cannot code as probable is HIV and AIDS. It has to be definitive. It has to be diagnosed in order for you to actually code that for an patient. Multiple coding for a single condition. If you're coding for a single condition and you need 2 codes, there will be directions given to you. You will be told to code first. You will be told to code, if applicable, any casual condition first. You will be told to code also, and you will also be told to use an additional code. When looking up your codes, you may also see that when you're looking at a code that, or a diagnosis code, that there will be 1 code outside of brackets and 1 code inside of brackets. Whenever you see 2 codes listed, 1 outside of the brackets and 1 inside of the brackets, you need to make sure that you code both codes. When coding for acute and chronic conditions, if a patient's diagnosed as having an acute and a chronic condition, and there's not a combination code for it, meaning the diagnosis code will have acute and chronic. For instance, there is an acute and chronic code for respiratory failure. You only need 1 code to describe acute and chronic. But if you're looking at a code and it does not have that option, like say the patient comes in with acute renal failure, but the patient's also known to have a history of chronic renal failure, you would code the acute code first and the chronic code would go second. When coding for sequela, which is also known as late effect, it is a residual effect of a previous condition. An example would be is if a patient had a cerebrovascular accident, which is also known as a stroke, and due to that cerebrovascular accident, the patient has been diagnosed of having partial paralysis. That's a late effect. That's a sequela of the cerebrovascular accident. There's no time limit for when these codes can be used. These symptoms or a residual effect may occur right after the injury, like with a CVA injury, or it may occur a month or more later. When a patient is being treated for a condition that is a sequela of an earlier injury, you will need to reference the word sequela in your index to diseases. When coding for a sequela, there may be 2 codes required. You will need to code first the residual effect or manifestation condition. Then you need to code the sequela second. You may need to code from the external cause of injury if a patient's sequela is due to an old injury, such as a car accident. Okay. You will need to code for the sequela of the car accident. There are some circumstances where you may have to code for the sequela as your principal diagnosis, and that is when that's all the information that you have available. And that could be, one of the reasons would be to code for the sequela is if the patient has a sequela due to an old injury, previous illness, an illness or injury that occurred 1 year or more before the current encounter. You can code those as principal diagnosis. When coding for an impending or threatened condition, you can actually look up the word impending or threatened. If you do not see a code listed for that particular impending condition or threatened condition, you will have to code for the symptoms only. Okay. Reporting the same diagnosis code more than once is not allowed. Okay, you should never have the same exact code listed. You may have a code that represents the right side of the body and a code that represents the left side of the body, but it will not be the same exact code. Okay, and when coding for codes that are representing laterality, you need to make sure that if you're coding for a right side and a left side, that there is not a combination of a bilateral code, because some of these codes are lateral only, you have a right and left. Then other codes do specify bilateral. So make sure you pay attention to that information when coding. Again, ICD-10-CM is very specific about laterality. If a patient has a right or left side of the body diagnosis code, you may have to code specifically to that right or left side if the options are available for you to code that way. If the patient is suffering from a complication or a problem that is bilateral, look for a bilateral code before assigning a right and a left code together. Okay? There is an unspecified code available if the laterality is not specified. So if you don't know if this complication is on the right side or the left side, you can code unspecified. When there is not a bilateral code available, you will code a right side and a left side code. If a patient is diagnosed with a syndrome and you don't see that syndrome documented in the ICD-10 book for you to code, you will need to make sure you code for the patient's signs and symptoms only. Documentation of complications of care. What that means is if a patient has a complication after a procedure or service, the physician has to document that complication as being related to that procedure or service. An example would be if a patient came in after a procedure was done and the patient was diagnosed as having an infection. The physician would have to state that that infection was due to that procedure. If the physician does not state that that infection is due to the procedure, you cannot assume that that infection is a result of that procedure. It has to be documented by the physician. That relationship of that infection being due to that procedure, again, must be documented by the physician. If you are unsure, you will need to query your physician. Borderline diagnosis, they are coded as confirmed unless if you look in your ICD-10 book and you see that if you look up the term borderline, there is a code that matches your diagnosis. So if the patient has borderline diabetes, if you look up borderline diabetes and there's an actual code for it, you will code it. If not, you will code diabetes. And that's just an example, okay? You're only going to code for signs and symptoms if there is not a specific diagnosis available, okay? The same goes for unspecified diagnosis. If you have a specific diagnosis available, you need to code that specific diagnosis. For example, patient comes in, the patient has abdominal pain, but the physician doesn't know what's causing it, so the final diagnosis is abdominal pain. That is a circumstance where you would need to code for that symptom. But again, if the physician is specific that abdominal pain was due to gastritis, you would code the gastritis because it's specific to that gastritis, okay? Another example, if a patient came in and the physician documented the patient had maxillary sinusitis, you're not going to code just sinusitis, which is the unspecified code for sinusitis. You're going to code the specific code for maxillary sinusitis because there's a specific code for that. So you're going to code to the highest degree of specificity, and you're going to make sure that you only code symptoms and signs if there's not a definitive diagnosis available. When coding for etiology and manifestations, a manifestation is a complication of a disease. I have an example on my screen of a patient having diabetic retinopathy. Now, retinopathy is a result of the patient having diabetes. Whenever that happens, if there's a combination code available, make sure you code that combination code which describes the fact that the patient has retinopathy due to diabetes. Diabetes causes a lot of different things. It causes neuropathy, it causes nephropathy, it causes retinopathy, and other complications. So there's a whole long listing of diabetes with manifestations codes listed within your ICD-10 CM book. So make sure you pay attention to that information. This concludes the introduction to ICD-10 CM. Again, if you guys need to reach out to me, please feel free to give me a call on the number below, which is the 1-855-263-3669.
to the lower left-hand side of the screen of your PowerPoint. You also can reach me at my email address, which is charris@learnmedicalcoding.com. Our website is learnmedicalcoding.com. Have a great day, everyone, and thanks for listening.